Hi, everyone. Good evening. It's Adrienne with Spark Study Club, and welcome to the presentation on proactive caries care, harnessing AI diagnostics and biomimetic repair for superior patient outcomes with Dr. David Silverstein. Before we begin, I have an important announcement about how to receive your PACE credit for this webinar. So about 1 hour after we wrapped up here, you'll receive an email to access this course module on our site, which includes the recording and a survey. You will also be able to download your CE certificate there. If you have any questions, feel free to reach out to us by email at support@Spark Study Club or by clicking the Contact Us button on our website. A special thank you tonight goes to our sponsor for this webinar, which is Vivardis. And lastly, I wanted to remind everyone to use the Q&A feature in the control panel to ask any questions. They'll be answered at the end of the session as time permits. Now, I'm pleased to introduce our speaker, Dr. David Silverstein. Dr. Silverstein is a Kansas City native who completed an undergrad at Emory University and dental school at UMKC School of Dentistry. He practices in the Kansas City area as a Heartland supported doctor and has been utilizing AI and Curodont to treat his patients for 3 years. He aims to help people overcome their dental fears by creating a comfortable atmosphere for comprehensive oral health care. Thank you so much for joining us, Dr. Silverstein. I'll turn it over to you so we can learn more about proactive caries care.
Thanks, Adrian. Good evening, everybody. It's an honor to be here with the Spark Study Club community. I hope this is valuable for everyone. A little bit about what we'll talk about tonight, go through some objectives here. We're going to talk about diagnosis and treatment planning for early lesions, understanding biomimetic remineralization and how that works a little bit, what the workflow is in the office, how to communicate about it, and without further ado, we'll go ahead and jump right in. So, honestly, for me, this is a fun topic and easy to talk about, not only because, I do it every day, so I'm practicing full time, but this is truly the state of the art, the state of the art of dentistry. And I think that expression gets thrown around a little bit, but it is bonkers to consider where we are in 2026 now, especially considering where we came from. And, I don't mean in the 70s or 80s, but I mean like all the way back, right? This is a 3,000-year-old human skull from the Aztec area from Central America that has healed bone after an extraction, right? So human beings have been helping other human beings with their tooth problems for a long time, right? Our profession is not new. So that was 3,000 years ago. Let's fast forward to like 300 years ago. Does anybody in the audience know where someone would go in the like 16, 1700s if they had a tooth problem? Where they might go? Some of you may have heard this before. I wonder if any of you you know, are thinking of it now. It was the barber. This was a real thing. So you'd go get a trim and a shave and have your wisdom teeth out, get your wig put on, and you'd be going about your day. I think about this sometimes when we're practicing, just how we have autoclaves and headrest covers and chairs that turn into beds and stuff. And one of the things that crosses my mind sometimes is this conversation that must have happened like millions of times. Hey, Bill, thanks for the haircut. I think next I need you to take my tooth out. Oh gosh, why is that? Well, it has a hole in it. Oh, okay, let me see. Well, I see the hole. Does it hurt yet? No, doesn't hurt. Well, to be honest with you, the hole is a little too small for us to take your entire tooth out. So I think we just have to wait, right? Um, so, of course, everything changed once we got our hands on this thing, the dental foot drill. It was a foot-powered drill. The bands that would power this thing were made of leather. So now, instead of just waiting until a cavity eats away the entire tooth, now we can take it out with a drill and treat it so our treatment area gets a little bit smaller. And of course, GV Black gets his hands on this thing and gives us the 5 classifications of carious lesions, and modern day dentistry is born, right? And the treatment area becomes smaller. And as time goes by and technology advances, the area becomes smaller and smaller still, right? So now we are literally microscopically preparing the surface of the tooth for restorations. We're doing endo, we're treating areas that we can't even see, down to the apical foramen of the tooth. Treatment gets so small that we need loops, and that is definitely the way things progress. Not only does the treatment get smaller, but our ability to detect gets earlier, right? So the radiographs, Marie Curie helps us get some radiographs, and now we can literally see inside the teeth. I mean, imagine for a second how bonkers, that's the second time I'm gonna use the word bonkers today out of three, I think, it would have been to have be a practicing dentist when radiographs come out for the first time and the film and they got to have a dark room and all the chemicals and everything, but to literally see inside the teeth and what those conversations must have been like. And the truth is that as our industry has evolved, there's this little neck and neck race between lesion detection and the ability to treat those lesions, right? So we have lesions that we can see, but what has been our plan for lesions like this that you can see on this slide with these white arrows, right? Well, we actually have a word for cavities that we can detect, but that don't quite merit treatment with current methods, and that's called incipient. Incipient is a word where it's like, yes, we have a lesion. We really can't justify fixing it right now. So what do? We watch these areas. Okay. So we're going to come back to that in a second, but we are going to talk a little bit about AI today because that's the other thing happening with the state of our art. Of course, I'm sure that for all of you attending this evening, I'm not the first person to bring this up. Our ability to detect caries has really just made an enormous leap forward. And in 2026, the state of what we do, patients are really expecting this, and I have a slide about that. But AI is really here for good. There is no area of what we do that will not have AI putting its little tentacles in there over the coming years, right? Record keeping, chart prep, scheduling. Literally, it's in an infancy right now. And in 2023, the NIH published a study, and this slide has a few numbers on it, but the main thing is the takeaway is that 60.8% of patients expect that AI will lead to improved diagnostic confidence, right? So they are expecting the use of AI in our practices, and it's over the next 1 to 5 years, 5 to 10 years. I mean, they know that it's coming. When I use this in my office, people don't blink an eye. They don't ask, what's that? Everybody kind of knows. And to be honest, I was a little apprehensive about that in the beginning, but patients were just like, yeah, this is normal. So we're going to look at how AI can help, with radiographic evaluation. And it does so, by the way, by analyzing the raw digital image data, the ones and zeros that come from the sensor itself, right? It's not the human eyes looking at the different shades of gray on a black and white and gray image. So the areas, that it highlights for us, it's really suggesting just a need for evaluation and a potential diagnosis. Of course, it's not making any treatment plan that happens by the dentist. But one feature that I use every day, all day long, is this one called patient view. For my patients, I call this the cartoon. So I'm going to put this cartoon up. This is the x-ray that we took today. Do you see these areas? If it is truly a cavity, I will say this is a cavity in your tooth, and it makes it so much easier to see. I'd no longer have to explain where the enamel is, where the nerve is. It makes it, so really puts it into layman's terms. We do have a few examples of the power of this. So if you just want to take a second and look at these x-rays and see if there are any lesions that jump out to you. And then the next slide is the same slide with the patient view. So you can really tell, if I go back and forth, kind of where those are. Now, keep in mind, this isn't making a diagnosis. This is just bringing our eye, the clinician's eye, to the images. Here's another example. It has a little watermark on there, sample image, but it is true nonetheless. So I'm not sure if you were able to see those beforehand. You can sort of see them now when I put that on, but it really does help me make sure that I'm, not being biased or sleepy or ready for vacation or anything like that when I'm looking at patient x-rays. It really helps with accountability. The truth is that none of us drive home after a long, hard day treating patients, thinking to ourselves, I probably missed some decay today. None of us think that. We all do our best all day. And when I got, this technology in my office, I was more excited about the patient view than I was about the accountability part. The truth is that after using it for a few years now on a daily basis, I mean, every single x-ray we take, I look at through this, not necessarily all through the patient view, but all with the help of the AI. And the truth is, whether I'd like to admit it or not, that there have been lesions that I've had to say, yes, this is one that I wouldn't have noticed this without it helping me, get my attention focused on it. So this is the same slide from earlier. And I'm going to ask, how do you handle lesions like this in your office now? Um, what is the good of being able to find them with the help of AI without the ability to treat them? Well, lucky for all of us in 2026, now it is, we have not only the ability to find them earlier than we ever have before, but also now the ability to treat them with a product released by a company called Vivardis, who's sponsoring this CE. And with this product, we no longer watch or monitor these areas. In my office, we treat them every single day. Okay. So this is definitely the state of the art. It is really incredible to have access to these two things at the same time. Really, just by coincidence, if you ask me. Um, where is this coming from? So first of all, it's important for you all, and as I also had to learn, this product is not new. It's got decades of research behind it, literally hundreds of publications, systemic reviews, meta-analyses. More and more studies are being published each year, and it just came to the United States about 4 years ago. This guided hydroxyapatite generation. So, we're going to talk about this a few times, but what I'm talking about is a protocol where we prepare the tooth by removing the pellicle. We place the solution onto the tooth, and the solution on a microscopic level diffuses throughout the lesion. And we're going to talk a little bit about the word biomimetic. We all probably remember that from dental school. But the word biomimetic means that it is literally mimicking what happens in life, um, rather than some sort of external medicament or a resin, as we'll talk about later. And over time, we can watch these areas stop in their progression and oftentimes even show radiographic improvement. And it's suitable for all patients, children, elderly people. We'll talk a little bit about indications for you. So, the key to understanding this is that this medication is suspended in a solution that we'll show you, and it diffuses throughout the lesion in the enamel. Okay, it does not stay on merely the surface level, it diffuses throughout to the depth of the lesion. And it forms a scaffold which will attract minerals from saliva to generate new hydroxyapatite. And like I mentioned before, it's biomimetic in its action. This works by absorbing and attracting the minerals that are already in the patient's saliva, right? We're not filling the tooth with an artificial material, or we're not having any sort of a margin around a restoration that can leak or fall apart over time. It's pretty incredible that for the first time now, instead of the minerals in our saliva just making plaque into calculus that we then have to go clean off. Now we're harnessing the power of those minerals to literally build new hydroxyapatite. It's pretty amazing to see this. Where is the hydroxyapatite formed? So, of course, whenever new technology comes out, we want to really study it at the microscopic level. This was a study done recently in 2025 where a scanning electron microscope was used to evaluate after treatment. And it showed that not only was hydroxyapatite formed at the surface, but throughout the entire lesion and to the depth of it. So at the bottom of the lesion. An important distinction, from fluoride and other sort of medicaments that we use, that it really goes throughout the whole lesion. And then after 2 weeks, it was shown to have a 15% mineral deposit throughout the lesion. This is something that happens over time. So with my patients, I tell them, hey, we're going to apply this now, and then I'd like to see how this is looking 6 and 12 months from now. I give them the expectation that this is not going to, be something that happens overnight or over the course of a couple weeks. But it is amazing to see the mineral deposit happening after just a couple weeks, shown by the scanning electron microscope. Okay, so what exactly is this intended for? Okay, the quote that I would want you to think of is it is for demineralized, non-cavitated lesions in enamel, right? Those words are just really all you need to remember. It is for smooth surface areas like around orthobrackets and interproximally, of course, um, and some occlusal surfaces. It is not intended for dyschromia or, areas where the tooth looks white. Sometimes that's hypermineralization, white spots that have been there for 30, 40 years, decay that is into the dentin, right? This technology is not designed to rescue a what should be a class, 2 filling and see if we can pull it back to just being the enamel. This is indicated for, like I said, demineralized, non-cavitated lesions in enamel only. It's not indicated either for developmental defects like enamel hypoplasia or fluorosis. Personally, one of my favorite and most rewarding places to use this is in that third picture there around orthobrackets. When you take that Explorer and you can just feel on those areas, sometimes it's rough. And because, this patient might be 14 or 16, these lesions haven't been there for 20 years. And when we place this medicine on there and we give good home care instructions, the patient can do a good job. One of the most rewarding things for me as a dentist is 6 months later to put my Explorer tip on these lesions and nobody else in the office gets to feel this except me, maybe the hygienist too. But, when you put your Explorer on there, it is rock hard. It's glassy smooth. I can tell no distinction between the enamel and the lesion that was treated with Curodont. And it's really just such an incredible, incredible thing to experience the way it feels so differently. So, patient education and communication. How do we talk about this, right? So, like all the treatment that we complete in our office, our patients need to feel confident in our ability to diagnose it and treat it, and they need the same communication from the entire team. We can't be calling it different things, but from different people, that's confusing. So I want to start with a simple question. Okay, looking at this picture, right? We're switching gears a little bit, talking about cars. Here are two customers. Okay, which of these customers is already aware of their problem, right? The smoking hood, that person knows, oh my goodness, I got something wrong with my car. The person on the right, they might or might not know. They might not be aware, right? And they might be in for an oil change and you might see this and be like, "Oh my gosh, it's getting cold soon. It's gonna rain next week. Like this person has a problem. I need to help them understand." So if they're not aware, it's important to have a different approach to the conversation. And the reason why I showed this slide is because for the vast majority of our patients where we treatment plan Carodont, there are no symptoms, right? They don't realize that they have a problem. There's no pain or anything like that. So our first task is always, always, always to help the patient appreciate, hey, we got a problem here. And in my office, we do this by showing the patient. I really never, ever want to say something to my patient along the lines of, well, I can see it, or just got to take my word for it, or trust me. I'm like, no, no, no. Let's look at the scan together. Let's look at your x-ray together, right? So we use a lot of intraoral photographs. We use the iTero scanner all day. That thing probably has miles on those wheels by this point, just in my little office. Sometimes I'll get the patient mirror and I'll say, hey, hold this up while I look at, these. I want you to see these. And of course, the AI patient view on radiographs, like we talked about. And my hygienist is the one who's doing the preheating for this, right? So my hygienist will she will describe for the patient what she is seeing and then she'll say, hey, Dr. Silverstein, I was talking with George here about some of these lesions on the x-rays I reviewed with him and how they haven't made it through the enamel into the dentin yet. So if possible, we'd like to treat those with Curodont today after you take a look, right? She's just helped the patient understand we have some things that we might make a treatment plan on and what that treatment is likely to be. And of course, she and I have worked together for years. So she knows, what I'm going to see. And she and I are on the same page clinically as far as how we diagnose, and I diagnose. She doesn't do the diagnosis, of course. Okay, so with these lesions, if you're going to incorporate Curatant into your office, which I highly recommend that you do, to offer, the state-of-the-art standard of care that we can, I would suggest that you don't minimize your language at all. These are not small cavities. They're not getting started cavities. They're not pre-cavities. I will say this. Hey, you have got a cavity in your tooth, but we are catching it before it's made it through the enamel. It's not through the enamel yet. And the best time to place it is after we've cleaned your teeth, but before you've eaten anything and the bacteria has started to, make that plaque on your teeth again. And the best thing is that we don't need to do any numbing or drilling. I'm not going to put a filling in there. And the goal is to hopefully never have to do a filling, which is great. The word yet is the most important word on the slide because it implies that it's dynamic, right? It hasn't gotten through the enamel yet, but that is something that happens over time. It implies the consequence of doing nothing. I will be honest with all of you. I was apprehensive years ago about how are my patients going to take this. But after doing it every day for a few years, I will tell you quite simply, when we find these lesions, it is a celebratory conversation. It is not bad news. I mean, the patients are literally like, oh, thank you. We don't have to do any drilling. I'll tell them, I don't need to schedule an appointment with you. We're going to do it for you right here before you leave. It takes just just a minute or two. And I see people's faces light up. I see relief. I do not see like, oh, darn, even though I just told them they have a cavity. So I think they really appreciate the way that we're trying to be as conservative as possible. Okay, what is in the box? There's not a whole lot. It's Unit A, which is a sponge. Unit B has the droppers with the liquid and some instructions. Um, you will need some things in the operatory, some etch, some unwaxed floss, some cotton pliers, some way to isolate, some cotton rolls. But in my office, everything that we need to apply this is kept in the hygiene op, so my hygienist does not need to get up and go run a bunch of errands and pit stops. Okay, so how to do this? So number one is to etch the tooth. Oh my gosh, this is a lot of animations here. We're just gonna click through all those bad boys. Okay. So you peel off the cover and you put the dropper of liquid into the sponge and it needs to sit on there for 2 minutes. Okay. While that's sitting there, of course, you would clean, rinse, and dry the tooth to remove any bacteria, remove the pellicle, make sure it's nice and clean. And then you do etch the area just with the normal etch that we all use every day. Not more than, 20 seconds according to the instructions, and you use some unwaxed floss in the interproximal areas to really floss the etch in between the teeth to make sure that it gets fully, applied to the tooth surface. And then, of course, you rinse it off and dry it. You'll then pick up the sponge with the cotton tip applicators, make sure it's fully saturated. You isolate the teeth, which is not hard to do. And then you'll apply it by squeezing that sponge for 5 seconds on the areas, the lingual embrasure, for the first 3 seconds, buccal for the last 2 seconds. It is literally that fast. Okay. It takes, 2 seconds to place on, and then you just tell the patient, hey, no food or liquid for 30 minutes after. And it is okay to place fluoride varnish after. That will help. But this is the workflow. So we're going to talk a little bit about the workflow, like how to integrate this into your practice. Like I said before, this is how we do it in our office, a dozen times a day. So we'll take images, we'll preheat the patient with the hygienist, we'll help the patient understand what's going on. Then I'll come in, I'll confirm the diagnosis, and we'll make a treatment plan. In my office, we always review all treatment finances and insurance coverages or negotiated rates or anything, what the patient's portion will be before we complete any treatment. And then, Curodont is placed the same day. It is very rare that we would ever schedule a patient to come back for that unless the patient was like, oh my gosh, I really have to get out of here. Like I need to leave right now. And I don't recall the last time that's happened, but I'm sure it does happen from time to time, right? So the treatment plan is reviewed. The Curodont is placed after the cleaning. Like I mentioned before, all the materials are kept in the hygiene room. It takes just a minute to place this. If your hygienists are like, oh my gosh, I don't know how you could add another thing to the list of things that we're going to do, make sure that they're aware. It's harder to place a sealant, I would say almost than it is to place this. It's quite easy, and we've never had a patient question like if it smells or tastes bad or anything like that. Sometimes, if your hygienist is running behind, we will use teamwork a lot in my office. So, one of my dental assistants will get her next one started, taking x-rays or polishing or whatever, so that she can do that after the treatment plan is completed. Um, and for any hygienists who are, needing a lot of support to make sure that they're doing it correctly, there are excellent, excellent educational resources. There are pamphlets, there are flyers, there are instructions that come in every box. There are videos, I think, that are very easy to access. So that's just one thing to keep in mind. Um, there is definitely no need for a second appointment. Sometimes we will complete Curodont treatment at other visits, though. So obviously, number one in the hygiene visit. At the restorative visit, if we're going to do some fillings in the upper right, and then let's say, number three along the gum line was not a lesion that required any mechanical, removal of enamel or tooth structure, just needs a little curodont placed on there. So what we would do is we'd complete the fillings on the upper right, and then we'll say to my hygienist, "Hey, we're ready for the curodont before the patient leaves," and she'll come into my room and place it. Sometimes with ortho checks, I offer Invisalign to my patients, and sometimes people will have, some lesions around their brackets or around the gum line that we check. So sometimes the hygienist will come in for ortho appointments to do this as well. And like I mentioned, if she's in the middle of polishing her patient, sometimes my dental assistant will go finish the polishing and the flossing for the cleaning, and then the hygienist will come do this. I was worried about that in the beginning. Like, won't the patient feel that their appointment has been interrupted? But man, to be honest with you, the patients are just, they totally go with the flow. They understand everybody's helping everybody. And, I think people really appreciate not having to come back for a second appointment that we can honor their time. Okay, what is the goal of this, right? So, when this is placed on a tooth, the research has shown over 90% success in the formation of new hydroxyapatite, right? What do we see, right? What are the outcomes that we can see? So one of them is stopping the progression. So you can tell on the x-ray that okay, it hasn't gotten any worse. And the other is that we can sometimes see a radiographic improvement. It's always great when we see that, but it doesn't happen every time. And there are a bunch of different reasons why. But the main thing is that it stops the progression of the lesion into the dentin. And like I mentioned, the success rate that is shown in the studies, over 90% success rate. If I'm being honest, what I'm seeing in my office personally, I would estimate it's more than 90% that we see. It's very, very rare that we place this and we don't have a great outcome from the treatment. Okay. Of course, the long-term prognosis of this treatment, like any treatment that we offer, will depend on home care and patient-specific factors like, their hygiene, their diet, their genetics, any underlying systemic conditions. So of course, we don't make any sort of guarantees or promises. And, if you place this and your patient starts chugging, a liter of Mountain Dew every day, chances are, that the caries they may not, look better in 6 months. And in fact, they may have new spots, but that's the same as if we were to place, a bunch of class two restorations and then they drink Mountain Dew for 6 months, we would see the start of some recurrent caries around those fillings that were just placed. So it really is a hand in hand success that, with provider and patient. Of course, I call them the tooth owner. Okay, so let's go over some before and afters. And like I mentioned, it's always great when we do see that radiographic improvement, and it does happen often, but not every single time, right? So in this one, we can see the top is the before, and then the bottom row is the after. And that's kind of nice to see how those, are not as dark. In this one, the Vidia, which is the AI software that I use, on the top, the red box is showing a lesion that's closer to the end of the enamel, and then the yellow box on the image below shows at a 4-month follow-up, and that shows that the AI, which is an unbiased evaluation of the radiograph, is showing that that lesion has, instead of advancing, it has regressed into taking up less of the enamel, which is pretty amazing. to see that confirmation from the computer. We have some other examples here. So this is another one where the 4 month follow-up did not show any highlighted areas with the, I'm pointing with my finger at the screen. I guess I could use the mouse so you guys can see where the AI is highlighting a lesion here and here, and then on the next one it is not. I think if we squint and look closely, we can still see it, but it does look better. And of course, the AI is confirming that it is decreased in size, which is great. Here's another spot, sort of a similar thing. Okay, so is there any benefit in patients with oral hygiene? This is a question that made me, ponder for a second the first time I saw this slide. But basically, what this study was analyzing is, okay, if we place Curaden on a lesion and the patient does not improve their home care at all, and they do not have good oral hygiene, what this is showing is that the home care is not a contraindication for use of Curaden. Basically, there is no harm that's going to come to them. And if this medicine is placed correctly on these lesions, we will see the generation of new hydroxyapatite on these areas. Now, will that mean that that tooth is treated for life and the patient has no future problems in that spot? No. It's just saying that it does make a benefit on these patients. And even if you have somebody who doesn't have exceptional Olympic level home care, as I like to say, this is still a product that will benefit the tooth structure regardless. Okay. Looking at what kind of impact this can have on your practice. So, as always, without, of course, we need to say in the beginning of a slide like this, the primary objective of hopefully all of us is offering and increasing the quality of our care and the benefit to the patient, right? So now that we're aware of how to find these lesions earlier and that we can treat them instead of watching them, to me personally, I feel an obligation to my patients that if there's a way to treat these lesions, like I got to do it. How am I going to say to a patient, well, the technology was there, but I didn't use it? That's just me. I feel, an obligation to use this, judiciously in the office when needed. These three groups on the top of the slide are three different size practices. So for each of you, you may fall into a different category here. But, about 80% of our patients that come in are Curodont candidates. Okay, that's statistically. And the research has shown about a 30% case acceptance. In my office, it's higher than that. In fact, I would say that the case acceptance for Curodont specifically is one of the highest out of any treatment that we offer, which is pretty great. So if you run those numbers, 80% of the patients at about a 30% case acceptance, you can see that this treatment really does add up. And depending on what you are deciding to charge for this in your office, this is something that really can have a benefit to your practice and your bottom line. This isn't just something that you offer to your patients and take a financial hit. This will really help you grow your office as a result of increasing the quality of the care that you offer, which is pretty great. A little bit about how to implement this. Obviously, whenever you're going to implement a change with your team, you really want to have an action plan in order to bring this back and make it work. So you want to update your diagnosis guidelines and have a team meeting. Explain to your team what this is, share your excitement about it, and help them understand your new diagnosis guidelines. In my office, before this, a lot of the lesions, we would watch them. My hygienists knew when to place a watch and they knew what I was watching. And then when we introduced this to our office, and over the course of a few months, the technology gained our trust, and we changed the diagnosis guidelines in my practice with the help of having this new treatment modality. But it was a process. It wasn't something where, you just turn on the light switch and now all of a sudden, your whole practice has changed. It was a journey of figuring out our language and how to fit it into our workflow. Um, of course, reviewing the morning huddle. I don't know how many of you do a morning huddle, but it's always nice to plan ahead and see who is eligible for this based on, x-rays that were reviewed previously. And, for having some goals, if we don't set goals, then a lot of times that's when things become dust collectors in our office, right? So I don't want any of you to buy this and then, 6 months from now, it's something to dust off. So you want to set some goals, track your case acceptance, and how many are being placed each day, each week, each month by how which hygienist is placing the most more of them. And you want those goals to be measurable, right? So you want to pick a number that sounds reasonable. Maybe in your office, it's like, hey, let's just see if we can get two patients treated with this per day. And then maybe it's, three per day or four per day or whatever, and obviously you don't look into a patient's mouth seeking to, do treatment. We simply look at the teeth and we let the teeth tell us what they need, right? So, but when you look back, it's like, okay, is this something that we are seeing executing in our office and we're having success with it, or do we need to make a change somehow? My encouragement would be for everybody to make this technology part of the treatment that you offer in your office. Um, More than once, I've heard that, state dental boards with this technology are considering, do we need to change what we consider the standard of care? Is watching incipient lesions now below the standard of care? It's just a question. And I think it's an interesting one. It really got me thinking. Anyway, I hope this was helpful for all of you, and I really appreciate your time and attention. And we definitely have some time left for some questions.
Okay, well, if you have a question at this time, now is the time to put that question in the Q&A section, and I can read off a few that I see coming in. Um, Thank you for that very insightful presentation on proactive caries care.
My pleasure.
I learned a lot. I'm already trying to figure out what doctor I could get to use this product for my 12-year-old son. It's absolutely perfect. Teeth to watch and lesions with braces. It's absolutely perfect product for him. So that's very exciting. This product sounds amazing. Okay, so let's see. We have, oh, okay, how do patients and or parents typically respond when you introduce Caradont as a treatment option? Are they generally receptive to this approach? I mean, I know you noted that they seem almost relieved. Is
Yeah,
that
I would
generally?
say, yeah, that's a good question. I would say relief is the thing, and I learned to not say you have a pre-cavity or an early cavity because it sounds like, well, then what are we? Sounds like there's no problem. Like, what are we
Mm-hmm.
talking about? And the truth is that, the word incipient means a cavity that is there in the tooth, but it just doesn't justify drilling. So I think in these areas where we can treat the lesion without drilling, it, like I said, it is a celebration. I think that after I tell the parent, like, hey, we've got some cavities, but the good news is that we don't need to drill on any of them. We're going to put some medicine and heal them from the outside since they haven't burrowed themselves into the dentin yet,
Right.
into the inside of the tooth. It's really accepted like, like a, oh, thank you very much. And, if I ever do have a question or a follow-up, one thing I'll really try to help them understand is the best thing that we could do for a virgin tooth that's never been drilled is to keep it a virgin tooth. We're not starting that cascade of treatment that happens. If somebody gets a filling when they're 12, and let's say it lasts until they're 32, right? 20 years, that's great. But, at some point that might get recurrent decay or need to be replaced. And then that has a lifespan. Then we're talking about a crown. And by that point, the tooth has had a cavity and then drilled on two or three times, so it may need a root canal. And it really just start that whole cascade. If we can avoid that from the get-go, and then that person can be a 32-year-old with a tooth that's never been drilled. And that is really like it's a miracle. I mean, honestly, and that's my own opinion, but it feels like Star Trek dentistry over here. We're putting medicine on cavities and we're not having to drill on them. It's amazing.
Yeah, definitely. Um, okay, I have another one. How is this different than a 5% fluoride varnish?
Yes, this question comes up a lot. So fluoride varnish is effective at the surface layer only.
Hmm.
It does not penetrate or diffuse throughout the lesion into the depth of the lesion. So it's kind of something that I would say as an adjunct for most of my patients when we place this. We have a lot of patients who are on, prescription toothpaste, Prevident or Clinpro, 5,000 parts per million. The fluoride trays, sometimes we do those for some of like my head and neck radiation patients. And of course, the fluoride varnish is a common one since it comes in different flavors and stuff. But fluoride varnish is not a treatment for caries, whereas this is a treatment. I do not consider Curadont a preventative, it's a treatment.
Right. Okay. That makes sense. And how does this compare to Icon?
Yes, good question. Okay, so Icon was introduced to me as something that can treat caries on, cosmetic areas of the mouth and has been advertised to address white spot lesions. And the way it works is by etching the tooth and then infiltrating the tooth with a resin. So a resin is something that will go into those areas, and it is the opposite of biomimetic. We are introducing an outside material, a foreign material into the body. Um, I think Icon is advertised as a cosmetic treatment. I personally do not advertise Curadont or tout it to be a cosmetic treatment at all. When we do have white spot, lesions that are incipient caries on the smooth surfaces of teeth, sometimes we honestly do see some improvement in the appearance. But I don't tell people, hey, let's look and see how much better these are going to look. This is really just to treat the demineralized enamel. Whereas Icon, you're introducing that foreign object, not an object, but the foreign substance. With Curadont, you're really using the ions and the minerals that are in the patient's saliva to form hydroxyapatite. It's like, you're repairing a demineralized tooth with new tooth structure, right?
Hmm.
Does that make sense?
Yeah. There was another question here that said, can you explain the difference between CDF and Curadont?
Oh, yes, silver diamine fluoride, SDF. Yes. Okay, so that is a good question. I think in the beginning, SDF might sound like kind of the same thing. But the problem is that they are treatments that are done at the opposite end of the decay spectrum, right? So Curadont is placed on incipient lesions that you're trying to never have to drill on that tooth, whereas silver diamine fluoride is what I would personally consider a Hail Mary treatment on caries that have all but destroyed the tooth, and you're really just trying to delay needing to remove the tooth, right? So, or avoid that. So, we're thinking about primary teeth with, really rampant caries, or, I have some patients who are elderly. I have a woman who is 98 years old and she has this giant, cavity under this crown, number 18. She's a sweet lady. She was just in last week. And every time she comes in, we'll evaluate it and see if it needs more silver diamine fluoride in the area. Of course, it's black under there. And it's all just to try to avoid having to put this poor woman through an extraction, which at her age would be pretty hard to recover from. Silver diamine fluoride is at that end of the spectrum, whereas Curadont happens at the beginning. Obviously, silver diamine fluoride turns the teeth black. Also, Curadont does not do that. It's another obvious one.
Okay, I have another one. What were some initial hurdles in adopting Curadont and how did you overcome them?
Yes, that is a great question. This will take me a minute or two. So, the first hurdle that I had, honestly, was myself. I was like, okay, is this fake news? Is this like, can this be real? I mean, I had some doubts about it, and I just decided that in order to make sure that I was offering the best that I could offer to my patients, I owed it to my patients and to myself to really just give this a try and see what it was all about. So with my hygienists, I think I used the word invite. I want to invite you guys to try this with me. I think this is going to be pretty revolutionary if it works the way they say it does. I didn't tell them that it works because I hadn't used it before and they knew that. I
Mhm.
didn't tell them we're doing this. What I did tell them is, hey, let's try this, and then I want you guys to give me all the feedback. Is it a pain in the neck to apply? Do the droppers, like, do they work or do they just squirt all over the room? Are patients complaining that it smells or tastes bad? Like, what complaints are we getting at all? And when I opened the door for them, they were like, okay, well, let me try it and I'll let you know. I will say after the fact, over time, it really did earn my trust. I place this in my office every day with confidence. I have never had a patient make a comment about a smell or a taste, and it's really nice. It's only 30 minutes that people can't eat or drink or rinse afterwards rather than like a couple hours or whatever, which is nice. I think one obstacle that we kind of had was with how we were talking about it with patients. I didn't want to say, hey, we got this new thing. One patient, I said, I've got this new medicine that I want to put on your teeth. And of course, the first question is like, well, you got give me a big discount. And I was like, yep, yep, okay. That makes sense. I understand. So we did. And now, of course, every time she comes in, she's like, hey, what's that new stuff? Can you give me another discount? And I'm like, all right, Jeanette, it's not new anymore. Um, you know.
Well, that
I,
that probably leads to one of these other questions in here that was asking how often it can be applied.
yes. Okay. So this is intended as a one-time placement. And to be honest, I cannot recall the last time in my office that we had to place it a second time. It does not do any harm to place it a second time, but it's really intended to work well when it's treatment planned correctly and the procedure to place it is done correctly when the protocol is followed. Honestly, what I see, the results in my office, we have not had to reapply. We have had to apply it to new lesions in the same patient, but rarely to the same lesion a second time.
Awesome. Okay, and so one last question, and then we're out of time. So if you have any other questions that didn't make it, feel free to, we'll actually make sure to contact you and answer all the questions that come in that weren't answered, because there are quite a few here, but we are running out of time. One big one was any advice for practices considering adding this to their preventative toolkit?
Yes, definitely team meeting. Um, Vivardis has been great about making sure that we all have access to a rep who can come to our office and literally walk us through it step by step.
Okay.
Some of us are quick learners, quick adapters, and other of us need to be, we're a little slower to trust. Um, I will say that it is really a good idea to have everybody on the same page, right? So whenever we add a new treatment to our practice, we're going to have new codes to talk about. We're going to have new fees, new insurance, things to check, new verbiage to get on the same page about that the whole team is using the same verbiage. And the other day I literally overheard my assistant answer a question. Patient was like, so wait, why do I need this if I don't have a cavity? And I was so proud of her. I just hired her a few months ago and I heard her go, oh, you do have a cavity. And I was like, yes, good job, Emma. So proud of you. So, but anyway, that language, everybody has to use the same language because some people can't call it incipient, other people call it, um, cavities. So anyway, that's important. Having everything in the room for the hygienist, our hygienists are busy. And if we're going to add something to them, the best thing that we could do is make it very convenient so that they literally do not have to stand to get it ready, which is nice. So she gets it out the 2 minutes. In that 2 minutes, she's etching, rinsing, isolating. And literally, you saw the slide takes 5 seconds to apply, and the post-op instructions are very simple. So, we tell the patients like, I really got to get back to work. How long does it take? I tell people it takes less time than flossing your teeth. And then people go, oh, okay. Well, if it takes
Yeah.
less time than that. Um, let's see. The only other thing that I would mention is that I think whenever we're adding something in our office, it is scary in the beginning because we don't know about it. So if you personally, if you're a dentist sitting there thinking, I just don't know, there's nothing stopping you from, giving each hygienist the, five applications to say, hey, the first five that we do, we're just going to do them for free. Just so we can all like take the money part of it out, just make it all about we're getting used to this. And those patients say, hey, we got this new product. We'd love to try it on our teeth. The research has been incredible. It's just new to our team. I have five free ones that I can do. I'd love for you to be, patients are pretty eager to enroll and stuff like that. I'm not saying you have to do that. I didn't do that in my office, but, when I started placing implants and I came back from my training and I wanted to start doing more, I think I had, for the first 3 months, everything was, and I did basically all the implants almost at cost. I was just trying to get my surgical skills up and get experience doing that. And of course, if you're presenting a treatment plan for thousands of dollars, you're going to have more acceptance when you say, hey, for you, let's go ahead and do this introductory rate. So I think, removing those barriers and making it easier for the patients, for the team, and for yourself to adopt to change, and just remembering that change is hard for everybody. And if a hygienist comes into your office with all sorts of obstacles and questions and like, I'm just not sure, just, welcome that, I would say. That's somebody who's interested. It's not apathy. It's just somebody who's maybe trying to get on board but has some probably very valid concerns or questions.
Thank you everyone for your questions. We've run out of time, but if we did not get to your question, we will answer it after the webinar via email. And just to let you know again, within 1 hour, you'll receive an email to access this course module on our site. And that is where you'll be able to get your CE certificate as well. This will include the recording and a post-course survey. Uh, Thanks again, Vivardis, for sponsoring this webinar. Great information. Dr. Silverstein, thank you so much for participating, and thank you for joining us, and we'll see you on the next one.